In today's nuclear medicine snack, we are going to look at the wild and wonderful world of white blood cells. In nuclear medicine, we can tag the white blood cell with radioactivity and then monitor how they spread in the body and chemotaxis present, and that is a way of monitoring infection and maybe some inflammation. So before we start, we would request some parameters that the doctor needs to provide us with to ensure that it's the correct patient chosen for this diagnostic procedure. We will look at C-reactive protein to see if there is some infection present. The erythrocyte sedimentation rate is important for the procedure and also to show if there is infection. And then white blood cell count is quite important because we need elevated white blood cells to have a good radio labeling procedure and harvest enough white blood cells for the study. Most of the time we look at leukocytes, but you can also split up the different white blood cell groups and just image a particular one. That is just a more laborious procedure. The infections that is prescribed by the European Association of Nuclear Medicine is acute infections, not chronic infections, and they come in various forms: fever of unknown origin, endocarditis, inflammatory bowel disease, infectious joints, diabetic foot, abscesses, lung infection, neurological infection, and central venous catheters that are infected. For all of these, it should be acute of nature and a high amount of white blood cells should be immobilized. So, your patient has signs and symptoms of an inflammation or infection. You do white blood cell scintigraphy, and what it helps you with is to localize the site of infection. So, indeed, you know now where it is, and maybe you can take a biopsy and see what type of bacteria is causing this problem, or the extent of the infection of inflammation. Maybe there is other sites that also have infection, you won't know. Not all of these sites of infection demonstrate pain or symptoms. Just as a good example of what you would look at is if you have a prosthesis in a patient that is giving them pain and some symptoms, you would want to know if it's just a loosened prosthesis without infection present or inflammation present, or if it indeed has infection. If it has infection, you will have to treat it before you do some surgery. If it's not, then you can put the patient directly into surgery. I want to thank Nastasha and Politife for this particular slide. So you would take radioactive technetium HMPAO, which is a lipophilic drug. You will use this lipophilic radiopharmaceutical to label your white blood cell with. It crosses the barrier of the cell through passive diffusion, and then inside the cell it undergoes some degradation and it gets stuck inside the cell. The normal biodistribution of labeled white blood cells is liver, spleen, bladder and colon and bone marrow. So you have to know what is the normal biodistribution before you can evaluate abnormal biodistribution. Please note that we also always do a 24-hour scan, so you have to inject quite a substantial dose of radiopharmaceutical or labeled white blood cells so that you can do an image at 4 hours and still be able to image at 24 hours. The difference in biodistribution between 4 and 24 hours does give you a clinical indication of the type of infection. The advantages of leukocyte labeling is that it can give you a whole body scan showing you wherever there is infection. So it's a whole snapshot of the patient and you can see additional infectious sites. You can imagine that an infection will not just stay at one place, and most often they could metastasize into other directions. So this is quite a big advantage of leukocyte labeling, and also it provides you a localization for further biopsies. The disadvantages is that you're working with blood. It is dangerous, it's a biohazard. You have to use aseptic techniques because you're removing blood from the patient, labeling it and putting it back into them. So you can't do this on a bench top or in an unregulated environment. It is time consuming. It takes more than an hour to label these white blood cells. The patient has to wait and you need to know how to do it. So people need to be trained, and it's quite a difficult procedure from a radiopharmaceutical perspective. The indication and stage of infection of the patient is important because there is a lot of times that the patient is not the ideal candidate for this procedure, and then it gets prescribed because you know, people want to see, maybe take a chance, hope for the best, or they are just not aware of the type of patients that is suitable for this procedure. There is two options as radionuclides: technetium HMPAO, which is widely available, cost-effective, and reduces radiation exposure, and then indium-111, which is not used that often anymore. So the accumulation at the site of infection is dependent on 6 factors. Where is this infection? How strong of a reaction does this infection have? The virulence, you know, is it a big infection, fast growing, a very strong infection? Where in the body it is spread, the extent of the infection, the type, which type of disease causes this infection, the blood flow to the area, as well as therapy the patient received. Are they on antibiotics? Does it suppress some of the reactions? Maybe cortisone? All of those makes a difference. I have to mention as part of the technical aspects that you have to exclude expanded bone marrow when you do white blood cell scans, especially for bone type of investigations. And this we do by nanocolloids that is labeled with technetium. They go to the areas of bone marrow and you can subtract that then from your white blood cell study. This is due to the reticuloendothelial system removing any particulates from the body. The method of radio labeling, like I said, takes some time. So you have to have your data first, withdraw the blood from the patient, isolate plasma, and then allow time for sedimentation. So we take the red blood or the whole blood, we put the syringes at an angle, we let it stand for up to 45 minutes, and then we gently remove the plasma from that because the plasma still has to contain the cells. It doesn't help if you do this by centrifuging the sample because you will also remove your white blood cells from the sample. After you isolated the plasma, you can then remove your plasma by centrifuging, and you will end up with a pallet with white blood cells underneath. This you label with radioactivity, you wash off the unlabeled activity, resuspend, do QC, and inject it into the patient. There is a lot of quality control going on. You first of all have to check the radiochemical purity of technetium HMPAO. If you want to know more about that, let me know. This will probably be covered in another lecture. You have to look at the yield of labeled white blood cells. So you wash your cells and then you look at the amount of radioactivity that is stuck on your cells versus the amount that was washed off. And then you must make sure that the white blood cells didn't die during this process or lose their function, so that we do by microscopy, and then we just evaluate cell death. So that is how far my snack goes for white blood cells. It is quite a mouthful, so if you have any questions and parts that you think I should explain a bit more, you can drop a comment down below. If you want to know more about any aspects or anything else you want me to present for you, please let me know. Please also subscribe to my channel, like this video if you found it informative, or dislike it if you don't agree with what I have said. And then I want to thank BioRender for the amazing program that they are providing the scientific world that allowed me to do the illustrations in this presentation. Thank you.